I'm delighted to be here, and it's staggering communications. We're all already doing social distancing across New Zealand, which is a great privilege to see it in action already. For those of you that may have watched my measles presentation, some of the beginning part's going to be the same. So I'd say the structure of tonight, where do these infectious diseases come from? And then I was going to do a little bit on influenza, because that's droplet-borne, the same as COVID-19, droplet-borne, and also relevant with the winter coming up. And let's just hope the two do not coincide, COVID-19 and influenza. And then we never know, and I'm certainly not hoping to instill any panic at all, just if it ever happened to become airborne, then I was going to cover Norovirus, because there's a significant part of Norovirus is airborne, plus it's useful to have on that, and then I'll ease into some of the COVID proper. So as Kathy has said, please email her anytime and with the questions, and I'll try and weave those into the story at the time. So where did it all begin, these emerging infectious diseases? We're a bit slow on the uptake. There was a primordial soup in the first place, and the first known life forms. The Earth started about 4,500 million years ago, 4.5 billion years ago. That's 4,500 million years. 1 billion years later, or a little bit less, after the moon had been plucked off the Earth by something collision, the first known life forms began. At this stage, I'll just add, it's not actually known when viruses started, because they don't fossilize. And so about 3.8 billion years ago, the first life forms, being bacteria, began. 1,000 million years, there's no oxygen. And so I put these dates in because these microbes are the ultimate survivors. They will survive anything at all, no matter what we throw at them. Temperatures, dryness, methane, carbon dioxide, no oxygen, they survive. And then 2 billion years later, the first much larger cells, called eukaryotic cells, which is the precursors of animals and plants, they then evolved. And 1 billion years later, these larger cells started coming together in tissue forms, which was the beginning of the tree of life. The Cambrian explosion suddenly began then. So there was arch competition amongst all these microbes, long before there's animals, and Darwin pointed out competition, survival of the fittest, or the most adaptable survived. And if we race forward to just a couple of million years ago, we then had hunter-gatherers. That was us in caves. And hunter-gatherers and small pods of people, and we roamed in small pods because we had to keep on the move to get enough to eat. Now, if that gentleman on the left there developed measles, for instance, it would race through those 5 people there, but it would have nowhere to go. What I'm saying is there were no infectious diseases then. We tend to think they've always been with us, but because we need a population to sustain them, and it would pass through there. One of those may die, but it couldn't go anywhere else, because the next pod of people was over the hill. They're our enemies competing for the same food. So it takes a large population to sustain an infectious disease. So measles, for instance, it takes about a minimum of 350,000 people to sustain it. We need some to be starting to lose their immunity so they can recapture it again in that population. Anyway, then we had a technological revolution which changed everything. We learnt to grow vegetables. And once we learnt to grow vegetables, we no longer had to be hunter-gatherers. We could stay in the one place, and we cleared the bush, and that was the beginning of us controlling the environment. So as we pushed the bush back more and more and more, the bats had to have somewhere to go, and so did the mosquitoes. Mosquitoes could no longer just bite the primates. They had to learn to bite humans and pass on the Zikas and such like along the line. But largely, these towns grew, because we tend to take things to the nth degree, so it grew. And where did infectious diseases come from? We know because we're close together, we're more efficient at spreading them than ever before. We know air travel, and we know large numbers of people in transit and trains, etc., commuting. We spread them around the world now very, very fast. But where's the origin of them? Most of them came from animals, because shortly after we grew vegetables, we could then start farming animals. And to feed that great monstrosity of a city we saw before, we then had animals also more and more efficient farming, and cattle more and more efficient. Incidentally, we pile antibiotics into them as well, so that breeds antibiotic resistance. And then we go to the wet markets in China, and they do similarly. All these different animal types together with lots and lots of people. So as our population increases, more and more people have direct contact with these interspecies live animals and their bugs too, whether they're viruses or bacteria. Now we know most microbes only stay within one species. Most microbes only stay within one species. We are not, unless it should mutate, we're highly unlikely to catch dog distemper. And similarly, our cats are not going to catch human influenza. Most species stay within their own territory. But we have about 200, we don't, the waterfowl birds have about 200 species of influenza, just like E. coli as part of their gut follow. 3 times per century, one of those 200 mutates enough to get into humans and cause a pandemic, influenza pandemic. We've had no exposure to that particular strain, so we have no immunity, so it hits hard. Until everyone in the world's been exposed, a number of them will die, and then we have a residual immunity to it, and we then have to vaccinate each year after that. And onwards we go with all these wet markets, that's live chooks and dead chooks all tossed in there. So once we got populations, then these plagues started plaguing, to excuse the pun, the earth. So we had the plague, Yersinia pestis, from the fleas and rats started going around across Europe, maybe 30% mortality rate as it spread across Europe and wiped out large parts. We also know in animals that there was a rinderpest virus which utterly decimated cows, but like HIV in cows. So that caused total social dislocation and political dislocation because these cows started dying en masse until we vaccinated and slaughtered them out, so there's no longer any rinderpest on the world, and which was the second major infection to ever be wiped out. One to animals, rinderpest, and the other one was smallpox around 1980, we vaccinated off the earth. But about 1,000 years ago, that rinderpest virus mutated enough so it didn't just infect cattle like it normally did, and one of those strains got into humans, those mutants, and that was where measles started, only about 1,000 years ago. We know that mythology tells us something about our own culture that we almost do not know. So when we have the Pied Piper, centuries before they knew how to, what caused plagues and such like, when we had the Pied Piper, then that told them something about their culture they almost did not know. And so the Pied Piper removed all the rats, and the plague, something else, I'll just get this back on again. And the plague went through cholera rather, later on, the cholera on the left with the ships coming in. When we don't have good information or good science, when the ships came in and their cholera outbreaks, they burnt all the clothes. But cholera is only in the water, it doesn't live in clothes. So sometimes we do things that seem like a good idea until we have more knowledge, and we're in that trouble with coronavirus or COVID at the moment, because we only know about 3 months worth about this particular strain so far. As opposed to on the right, I won't go into it, but John Snow, he plotted all where people died from cholera and then thought it must be from the water wells, and so he removed the handle from the water well, and that was the end of the Broad Street cholera outbreak. So when we have some knowledge, we try and do the best we can. So the rat catchers were employed once we knew where the plague came from to catch the rats, but for some reason the fleas that carried the Yersinia pestis that caused the plague didn't like staying on the rats. Now the association, whether it's for measles or whether it's for COVID, when we put ill people in one place, us healthcare workers have to up our game considerably because we're going to be more exposed in greater concentrations to those that are illest, and we've got to up our game. We've been brought up for hundreds of years to thousands of years to be utterly fearful and think all bugs are bad, all bugs are bad, all bugs are bad. Whereas they're not. Our 50 to 90 trillion bacteria in and on us are a key part of our immunity. But there's huge death rates came from these bugs over the centuries. 90% post-Columbus of the population of South America wiped out. 300 to 500 million of smallpox just in the first 2/3 of the 20th century. All bugs are bad, all bugs are bad. Spanish influenza, 50 to 100 million deaths when there was 1/4 of the population to what there is now. So we just have to be very aware of that. And that was with a 2% mortality or thereabout. So most of these emerging infectious diseases that emerge globally come from animals. And there have been 335 just between 1940 and 2004. And a large number of infectious diseases actually come from humans. I've got measles there, as I said, from the rinderpest virus, influenza from waterfowl. Brucella is a bacteria that's in animals, and that's one that doesn't go from person to person. We just get it from animals. It hasn't learnt to go rapidly person to person, and COVID virus as well. Ways of example, dengue fever. The yellow is prior to 1960, and now after 1960 it slowly travelled to a significant part of the world. Global warming may change that too. More recently we have Zika virus emerging, and then we have Ebola virus emerging, and then of course right currently we have COVID-19 emerging. And I had wondered, with all those cases on the Diamond Princess, has this virus mutated? Has it mutated? Has it suddenly got into the air conditioning and become airborne? Or was the infection control by the crew and others on the ship utterly hopeless? It was one or the other. It's either mutated and become airborne or utterly hopeless. And we got our answer about a week ago. A Japanese professor of infection control went on board and came out and said their infection control is utterly hopeless. That's why it carried on spreading. But you can imagine the challenges if you're in a hospital and you've got 3 times as many patients doubling up on beds, and you've got a half the staff. It's very hard, and some are feeling a bit crook. How do you keep going? How do you keep going? So we can see the troubles that happen in reality. And I'm not spending any time on these. I'm just showing all these infectious diseases keep going, ongoing, and you'll recognize some of the names there. Sometimes they have a go at coming and never get anywhere. So H7N9 was an emerging infectious disease, looked as though it could take off. This was 2017 cases in China, a form of influenza. And we have 2013, it started ramping up, 2014, the second wave, then the third wave, then the fourth wave, 2016 got really quite scary, and there's a 38% mortality with it. Then in the 6th year, there was 2 cases. They are always unpredictable. We just do not know. That could have been our current COVID, but it didn't. It suddenly stopped. So always unpredictable, and we must never forget that. There are emerging infectious diseases ongoing around the world. They tend to be regional, but sometimes they become global. And some of them are even man-made. We have bioterrorism and such like also to think about that can happen along the line. Now cutting to the nitty-gritty a little bit more, I wish to talk about a thing called rho values or R0 values. And it's like some journals put it as RT, transmission values. So it's the reproduction number, R0 value, the average number of secondary cases that you pass it on to, somebody with the infection, one person who's infected, on average, how many more people do they pass it on to, on average? So if the average person passes it on to 2 other people in any given population, then the R0 value is 2.0. If they pass it on to 1 other person, then it's only 1 other person. If they pass it on to 5, then the R0 value will be, if they pass it on to 5 other people on average, then the R0 is 5 value. When that R0 is less than 1, then the epidemic will be starting to come to a close because the average person with it passes it on to less than 1 person, so it's then coming to an end. And the higher that R0 value, the quicker is the transmissibility of it going on. When we look at different infections, in a non-immune population, and we hopefully have 95 to 97% vaccination of measles in the community, but in a non-vaccinated population, the R0 value is 12 to 18. Unbelievably infectious for 2 reasons. One, it is airborne, and somebody with measles, their virus fills the whole room, but more or equally importantly, not only does it fill the whole room, but the average person who's not immune only needs to breathe in between 3 and 10 viruses before they come down with it. So those 2 factors make it very, very transmissible. Ebola, on the other hand, may have been 1 to 2, a R0 value, but we only can catch that, or primarily only catch it, by blood or body fluids, going like we catch hepatitis B, blood or body fluids. The 1918-19 influenza was droplet-borne and had a low infectious dose because we'd never had contact with it before, so we had no innate immunity, had a low infectious dose, and the rho value was 2 to 3, and yet that still affected 50 to 100 million people in the world, killed 50 to 100 million people in the world, when there was 1/4 of the population in the world. There's only 2 billion people there. What is the rho value of COVID-19? We don't really know, and we'll get a better idea as time goes on, because we're dealing with only 3 months data with this COVID infection. So a lot of this is subject to change as we go on. So meta-analyses at the moment on publications show it may be 3.3, maybe 2.79. The WHO have just revised it up from 1.4 to 2.5. So the average person, because nobody, other than those that have caught it now, no human has natural immunity to it. And so 1 person with it on average will pass it on to 1.4 to 2.5 others. The seasonal influenza, the rho value is about 1.28 until we get nearer the end of the epidemic, because enough people will have caught it with symptoms or without and develop immunity. So we're thinking about that red circle at the moment, maybe the rho value for COVID. But we don't know how many people have got it without symptoms, the subclinical infections. And so I don't want to spend too long on this. You can look at it in your own time if you're going back on this link. This is the vaccine effectiveness. I know we have no vaccine now, and who knows, it may be a year to 18 months or more. So the vaccine effectiveness versus on the y-axis, how many people do we need to cover to make it effective? So if the rho value of seasonal influenza is 1.1, in other words, the average person passes it on to 1 other plus 1/10 more, plus 10% more, and if we had, and we don't, a influenza vaccine that was 100% effective, then we would need to vaccinate 10% of the population to get the rho value below 1. Whereas if the vaccine was only 50% effective, we would have to vaccinate 20% of the population to get the rho value below 1. It's the easiest to explain that. As this comes up, we can see exponentially how much better the vaccine has to be and how many more we have to vaccinate for it to be effective. It's got a lot of information in there in its own way. So now I think today, just looked up before coming, I think it's 118,000 infected cases, or known clinically infected. That's known cases. Those people that are relatively mild, and most COVID infections seem to be mild to moderate, will not be detected. So we know it's far, far more than this. And that affects the mortality rates, because the mortality tends to be on the known cases, but we're not sure what the true denominator is. And we cannot tell what the true denominator is until we do seroprevalence study. So bleed 1,000 people, say in a village where COVID went through, and bleed them all, and see how many, some months after, some of them had caught COVID, and see how many developed antibodies but did not develop infection. So it's a subclinical infection. They haven't taken in enough of the COVID virus to develop clinical disease, but nevertheless they've developed immunity. So when we look at the total cases, some concern, of course, because they're escalating so fast because of total deaths, total cases. Like always with maths, we have to be a little bit mindful of how we look at the data. So that's cause for concern, real cause for concern. Does it keep on going like that? But when we look at it on a logarithmic scale, which perhaps we would expect with a higher rho value, we have got some cause for hope there. And we see the Chinese numbers have come down. Now, was that because of extraordinary autocratic control on the population that stopped the spread? But fear will drive that for us as well. We will be staying home if it spreads that bad as well. So that, whether it picks up again in China or not, we do not know. But there's some cause for hope in a way, that when we look at it logarithmically, it's starting to tail off. We're right at the beginning of something, we don't know how it will go on. Now we look at COVID virus is remarkably similar to influenza. We cough, and it seems, on 3 months so far, that the high-risk zone is 1 metre to 1.5 metres from the person coughing. Now for influenza, the average person needs to breathe in more than about 800 virus before the average person is likely to succumb to seasonal influenza. And that 800 virus in practice is primarily in the large droplets within 1 metre to 1.5 metres of the person coughing. That's the risk zone. And or the hand, that hopefully you see that as disgusting, that nobody should ever cough into. We do that, and if my hands were clean or hygiened beforehand, they would be afterwards. So that is the risk zone. Now I just wish to point out that with a mask, if I have a mask on and I'm coughing, that's likely, even though the mask, even an N95 mask, only stops about 95% of small particles down to about 0.7 microns or thereabout, which is the size of a small bacteria like Staphylococcus, then that's pretty good to stop the bacteria, but we know the viruses are 10 to 100 times smaller. So you think, why wear a mask? Because it would just whistle straight through. But in practice, that's the science of it, but in practice, many of these large droplets, and many of the droplets or the water vapor, get caught up in that mask and do stop 90% of these larger amounts going past it. So that's why there is likely to be significant benefit with a mask. Yes, some of these influenza viruses will fill the whole room, but not at a level of 800. Not at a level of 800, which is required to have infection. But measles virus, if this person had measles, then it only takes 3 to 10 virus for somebody to come down with measles, not 800. So that's the value of the mask with at least a droplet precautions. Would you shake hands with a toilet brush? So I wanted this image, I just tried putting it together today. I don't know if it works. So how do you do? and which door handles have I touched? Who's touched those other door handles? Going through at airports, those security trays, we put our laptops and everything on. How many hundreds to thousands of people have touched that beforehand? So always think of your hands as contaminated once you've touched something that anybody else has touched. And don't pick your nose, pick your teeth, rub your eyes, try and keep your hands away, and use a collegial approach at your workplace to try and get people to point it out to you. And make sure, as managers or otherwise leaders, you'll be reasonably senior watching this, make sure you tell people, I want you to point out if I've got bad habits, and I'll thank you for it. And we need that collegiality to come through. These are the infection dose numbers, if you like. So every bug, there comes a limit over which the average person will succumb. So milk, old milk, it's really good to have the bugs. In pasteurised milk, we can drink it, and it keeps our immune system match fit. But if it's really old and it's stinking, then about 1 million per mil is infectious dose. Below that, our immune systems get match fit, and we will be quite all right. No symptoms. Salmonellas, greater than 1,000. Influenza, as I said, more than 800. We're likely to get infection. Less than 800, we'll just get antibodies and no clinical symptoms. Campylobacter 500, Staph aureus maybe 200. Pandemic influenza is going to be a lot lower because we've never had, same as COVID virus, it's going to be, we've never had contact with it before. We don't know how low it is for COVID virus, but at the moment it's droplets. So at the moment, perhaps it's around more, maybe a little bit lower than 800. We just do not know. Measles, 3 to 10. Norovirus, 10 to 20. And in other words, that's why it's so unbelievably infectious with norovirus. And with norovirus, when we have it, we have 1,000 million viruses per tiny milligram of feces or vomit. 1,000 million, and it's fresh, and it's a bit steamy, and we only need to ingest 10 to 20 from that 1,000 million. So that is airborne and a very low infectious dose as well. So with all infections, we then have the issue of, that's interesting, we have the issue with a microbe. What tends to happen, we get a microbe and the black, then our immunity starts coming, and there's a race. The race is on. Can our immunity knock that microbe down before it gets to the infectious dose for that particular bug? When it does, we've had a subclinical infection, but when it gets above that threshold for that species, then we get a clinical infection. Both will get immunity. How long that immunity lasts depends on the illness. Norovirus is just a few weeks, and whereas measles is many, many years. So just very briefly on, for the reasons I said, it hasn't mutated to airborne yet. It may never do so. Hopefully it dies out before that happens. But if it were to, very briefly on the norovirus, 1,000 million, I mentioned, we only need to ingest 10 to 20. And this norovirus, unlike influenza, is stable for at least 2 weeks, maybe 3 weeks in the environment. Chlorine washes it off readily. And we keep shedding virus in our feces, not just for the 2 days until we come back to work when we've had no symptoms. We still keep shedding the virus, but it's impractical to keep people off work for that long. So we can shed it for at least 4 weeks, but it's going to be lower and lower numbers and takes more and more contamination then to succumb to it. But we've got to be practical. Why are norovirus outbreaks so common? Because 7 out of 100 people get clinical norovirus every year in the community. 7 out of every 100. That's clinical. About 3 per 100 get asymptomatic infection. So that is why when we see it in rest homes coming up more, it is because it's increased in the community more, not because the rest homes are doing anything wrong. When it's more in the community, then the rest homes will get more. The rest homes are blamed for it, of course, but it's in the community that it comes from. And what's the evidence for airborne of norovirus? Well, there's been a number of papers published now. One, a huge concert hall where one person vomited during a performance, up in the front row I think they were, during a performance, and they were immediately ushered out or left the premises. Over the next 5 days, over 300 people succumbed to norovirus from that one person vomiting. And the nearer they sat to that person, the direct proportion, the higher risk they were of getting it. So if this ever becomes airborne, hopefully it doesn't, but norovirus does, then we have to have a completely different approach again. everything goes up. External window being opened helps dilute it out, but we really, really need to up the game a lot. Norovirus also, one passenger vomited on a long-haul flight. Over the next 6 days, flight attendants who had no contact with each other succumbed to the same unusual strain of norovirus, so we knew it was the same one. It's only one possible source. And then along the line, keeps turning off, does it? There we are. Magically turns off at times, and Andrew comes and reconnects us up again, in case you're wondering why it's cutting up. There was somebody who had vomited in a restaurant, and in direct proportion to how close they were, 2 metres, 4 metres, 6 metres, 8 metres on the restaurant was their chances of succumbing to norovirus. So we know it is airborne, which is why for norovirus I talk about double isolation. If somebody succumbed in a room and we attend to them and then close the door, but it may have already wafted out the door, or where did they catch it from? Likely to be a staff member, a healthcare worker. Where do they catch it from? And hopefully that healthcare worker only worked in that ward or wing or area. So if we double isolate that wing or area, that can help stop it spreading further throughout the hospital or facility or rest home. Double isolation straight away, if at all practicable, and it may not be, but that is to be thinking about for airborne. Now droplet-borne. Influenza. Some things, 1918-19 poster, some things haven't changed. And so have influenza, avoid crowds, walk to work, do not spit, cover each cough and sneeze with handkerchief. Well, we've learnt handkerchiefs maybe not as good as they could be, they get wet and soggy, so we use tissues now. This is something I want to spend some time on. People tend to think, this is Centres for Disease Control, WHO and New Zealand MOH use this for influenza-like illness, the case definition. You must have a fever and a cough and or sore throat. That's a case definition. Looks very similar to COVID, doesn't it? It looks very, very similar to COVID. And why I want to point this out is with influenza, people tend to think this is for trend analysis. And so we know even when patients are ill enough to be hospitalized, there's 207 patients over 3 years in the States, so it's useful because it was 3 different winters, that 207 patients, when they went back on, they were confirmed shortly after arrival at hospital, only 60% of them had a temperature, even though they were ill enough to be hospitalized. 40%, whether they're over 65 or under 65, had no temperature. And only half of them had a temperature plus a cough. 90% of them did have a cough. So what I'm saying is that would miss half of them. That would miss half of them. So we have to be aware with COVID or other similar ones that that case definition is going to miss lots. Probably the bulk. You have to be very, very aware of that. That's why we have to think anybody with a new cough and nothing else. Most COVID infections are mild to moderate. Anybody with a new cough must wear a mask. If you feel well, we have to be practical. If you feel well, if you have a new cough to you, it's not your normal COPD cough or allergy cough, new cough to you, wear a mask. It may be influenza, it may be COVID, it may be another respiratory virus. We don't want any of them, and we will not know normally if it was any of them. So wearing masks is critical. We must believe when we're wearing them, if they're working, they're not fancy looking things. If they're working, it's the equivalent of being much worse and smeared with feces across the front of them. So given that image, we have to take it off very carefully and get rid of it and do hand hygiene and not be touching it and feeling about and touching other things. It looks as though it will be pure, but if it's working, then it may well have hundreds of thousands of virus on it. Some things with influenza, so cover all coughs, some things with influenza come back like clockwork. So we see them coming back again and again, and each year in the winter time. But similarly with these droplet ones, from the Shivers, Southern Hemisphere, influenza vaccine, efficacy research study or some such thing, around 20% of New Zealanders catch influenza every year. but 3/4 of them have no symptoms. They get taken less than 800. So in practice, they're unlikely to be infectious if they're not coughing it. Unlikely to be infectious. They're not coughing. If you're kissing somebody, close partner, then yes, you'd likely pick it up. COVID may well be the same. We don't know until we do these seroprevalent studies. Then we only have 1/4 of them have symptoms. Influenza cases have symptoms out of that lot. But of those, 80% are not that ill. They will just have a cough, bit of a bad day, just have a cough, but be spreading it to others who may succumb badly. We have not a clue. Only the tip of the iceberg are ill enough to be hospitalised. So we must always remember that. But many people with, so similarly to influenza, we know COVID produces, the red line here is the virus. We know COVID, we have the virus in large numbers in the 1 to 2 days before we get symptoms, then we get the symptoms. But similarly, if we're not coughing, we're unlikely to be spreading. We're unlikely to be spreading if we're not coughing. And as I said, it's only the tip of the iceberg, actually, that fulfill the case definition in the community. When they're, and it may well be the same, that is why it is really, really hard to stop. And that is different to SARS virus. People think, well, we shut down SARS, why can't we shut down COVID the same? The difference was when we've gone back and done seroprevalent studies, looked for antibodies in the community of villages, for instance, that had SARS, those that had antibodies, nearly everybody had had a serious infection. And they did not start shedding or spreading virus until they'd had clinical infection for over a week. So it was the second week that they shed the most virus, and because everyone that had SARS got really ill, then we knew who to isolate, and so it could be stopped. We know most people with COVID have a mild to moderate infection, so we don't know most of the people that are carrying it and spreading it. But we have to be, so the tip of the iceberg, we also, and we've already seen it, many people will try and battle on. I'll battle on. And so I think it was in Sydney, was it? A medic recently had seen somebody carried on going, and then we've got all the contacts following on from that. So many people try and struggle on. You can see why. They look after their practice, justify it. We've got to do the best we can for our patients, but be spreading it on. We have to be very, and at times there's going to be a balance. If there's nobody there, how do we cover that off, etc., etc. So, emerging infectious diseases, I don't wish to spend time on this part. These are the factors that have helped them. International trade, susceptibility, we have more immunocompromised people than ever before, social inequality, breakdown, less money spent on public health, ecosystem changes everywhere. As we know, climate change, some of it is willful harm. There are many, many things that have helped bring it about. Infectious diseases tended to reduce in the 20th century because we had the vaccinations and we got better water and sewage and everything else, and then antibiotics was amazing, like a miracle. But in the last quarter of the 20th century, we started having increasing numbers and large numbers. And so we had some going down, smallpox right out, polio so close but not out yet, measles resurges because people don't vaccinate because they think it's gone, and then we have those going up as well, including down the bottom there, COVID and antibiotic resistance. So we have more and more people, it's spreading through Europe now. Clinical characteristics of COVID-19 in China that have had the biggest number of cases to go from. So this will change with time, but males, median age 47 years, males are more common than females to succumb. So fever, 44% on admission. So that does not pick up the mild to moderate cases. You're ill enough to be admitted, 44%. So see all those ones that miss the case definition. I'm just very mindful of that. Cough, not lots more, 89% during hospitalisation, but 68% beforehand. So cough once again becomes the predominant one, not as much as influenza. Median incubation 4 days, And X-rays are actually remarkably tomography, CT scans. So of those with non-severe disease, only 18% have no changes, radiologic changes, but those with severe disease, only 2.9% do not have radiologic changes. But we're not going to have radiology in rest homes and such like, and there's going to be a very vulnerable population there. So case definition, I don't wish to spend time on this, and this will change with time, but as I said, fever, and we can now see how many it misses. We can see how many it misses, which has given us the challenge, which was not there with SARS, that we're seeing the tip of the iceberg before we have that. So you can look up that on the New Zealand MOH site. I'm sure it'll keep emerging, but that is the challenge we have. We're largely relating to countries. Where have you been? Who have you had contact with? Have you got a fever? That's higher risk, clearly, but in practice, assuming it keeps developing, that's not going to be the majority of cases. Severe cases, these are the clinical characteristics, severe, and then critical, and then pregnant women may be, on the data so far, not as 1% were critical, 8% had severe disease. So it's maybe not like some of the influenzas, which was a lot more, but clearly we don't want it in them either. So that's the clinical characteristics of severe and critical. What's the fatality rate by age? Well, once again, look at rest homes, the 80 plus years, this is of confirmed cases and this is of all cases. So high over 80-year-olds. And 70 to 79-year-olds, all cases, still high, over 60, starting to creep up. The rest, this is from China, the rest really, really well done. How many retired medics that are watching this would like to pop in and help out? So we have to be mindful that there's some upsides and downsides to having. And so what I'm saying is if they do come in, or nursing or anyone that's older to help out, they have to be a lot more scrupulous still for their own protection with masks and hand hygiene, a lot more still. And we must be, if we're asking them to come in, we must be truthful and make sure they're aware of these risks. By gender, by sex, males a lot higher than females for death rates, all cases, and so that's confirmed case in all cases. So males, for some reason, 63% as opposed to 37%. So male healthcare workers coming back after they're older, even higher still, death rate. By comorbidities, it drives up the rates a whole lot more. So cardiovascular, diabetes, and respiratory drives up these rates a whole lot more, again, to just the age. So thinking of rest homes, all the comorbidities, maybe 2 to 3 average, and significantly old population there. We've got to be scrupulously careful on mask wearing and such likes in rest homes. Any cough is utterly unacceptable, and all staff must know it. For any visitors, not to wear a mask, any new cough, and any new staff, unacceptable not to wear a mask new to that person. So mortality rate by age, put this way, that's what it comes out to. And the under 50s get off remarkably lightly at the moment. We don't know if it'll ever change, but at the moment, remarkably to the elderly primarily. Case fatality rates have maybe come down 20%, coming way down, and we actually don't know because we don't know what that denominator is. We don't know how many people, so it may be lower than that. We don't know how many people have had light to moderate infections that have not been picked up. So another way of looking at this, outcomes, most people have mild to moderate infections with COVID, so most people recover by far. Might be well into the 90% people recover, and these ones are primarily in the elderly, especially comorbidities, and a comparatively small number. It's primarily the elderly with comorbidities, but there'll always be 1 or 2 that get caught out similarly. What is the recovery time? Well, The median time from onset to clinical recovery, perhaps not surprisingly, depends on whether it's a mild case, you recover more quickly, or whether it's a severe case, and that's a lot longer. And at this stage I'm going to mention, no, that comes up later, that's right, there have been also relapses as well. Okay, so I don't come onto it later. There have been a number of relapses reported in China. So people have become PCR negative, the test for it has become negative, no virus present on repeated swabs, their fever's come right, their chest has come right, and then they've relapsed with a positive PCR test and become ill again. So that's another thing to think about. I use this slide for every epidemic there is, and I call it a sane person lies, or number one looks after number one. So we saw it in Italy when they announced it leaked that they were going to close down Lombardy and the north of Italy, and suddenly thousands went to the central station to get out of that area, and so spread it more efficiently throughout the rest of Europe. And whenever there's an area that's going to be closed down, people do what they can to get away from it. And if they're incubating it, might be incubating it for 9 days or so, they're going to help spread it around the world by doing that. And so this person knew she was getting ill, she took a whole lot of antipyretics, reduced her temperature so she wouldn't be picked up at the border, got through to France, and she was bright enough to get out, but not bright enough not to boast about it on social media. So she then got picked up. But a sane person lies. In other words, number one does the best they can, even if it's somewhat selfish, to try and get away from it. We must be aware of that. Is this a one-off? Does it ever happen? Is this rare? Here we have the index person, arrived from China from memory, arrived in Germany, no symptoms until here. No symptoms until here. This person had no symptoms and attended the meeting and then had no more contact. The index case developed the symptoms then this person developed those symptoms there. These orange-red ones are contact with patient 1. So patient 1 is here. So this person, this patient 3, had contact there and contact there, but this person didn't develop symptoms until there. So it was passed on to them, and similarly, this person had contact there, 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 and there, and they developed symptoms. So this asymptomatic passing on, maybe it's 1 in 118,000, we just don't know what it is yet. Or is there another explanation? We don't know. Environmental survival is generally talked about up to 9 days for that the COVID virus will last. That's based on SARS and MERS. They seem to last for up to 9 days. To be fair, if I have COVID and I cough, and so it's a bit more like the Norovirus and cough, it will last in the environment for up to 9 days, but at lower and lower numbers, of course. If it lasts up to 9 days and we need an infectious dose, we don't know what it is, but I'll say less than 800, those numbers will be getting less and less, so I'd have to be touching a surface for longer and taking those viruses in once it got older. I just put a slight caution on, veterinary coronaviruses, they persist for longer than 28 days. So just be mindful of that. And the WHO says 0.1% sodium hypochlorite will, for 1 minute, will kill it very, very readily. 0.1%, as does alcohol, ethanol. Somebody emailed me the other day, what about meths? Which is a good question. They use meths normally with vinegar, as it happened. They used it in water diluted. I looked up meths in New Zealand, methylated spirits. It is ethanol now, but it ranges from something like 90% ethanol down to 60% ethanol, depending on the different type of meths that you buy. So if you have a type, make sure you look up to see what percentage it is in that particular brand. It's like to be ethanol. Ethanol works a lot better than methanol, incidentally. COVID-19 is not influenza. But it is a respiratory RNA virus, as is influenza. And these respiratory RNA viruses They break down very readily with hand washing and or alcohol. But they're hopeless at copying themselves. They produce lots of wonky copies. That's why we get the seasonal influenza coming back in a slightly different form each year. And if it was to mutate and cause future waves, the COVID-19, if it was, I'm not suggesting it will, I'm just saying there are some similarities, but if it was, would future waves have a higher or lower mortality? We don't know. And or would that rho value increase, because remember that virus is fighting for its survival. And if it can transmit more readily, it's a yee-haw for it. If it survived 3.8 billion years, it might go for another billion. So do past influenza pandemics help inform us or not? Now, the other ones are influenza. This is a coronavirus. It may or may not, but I'll just forewarned is forearmed. This is the 1918-19 influenza pandemic. All-cause mortality, but the influenza overtook the background general mortality rate. There was the first wave, as it happened in the summer. First wave was just a blip on the horizon. Then in their winter, the second wave hit and it took off. Of interest was New York on the hard line there, then Paris and Berlin. It hit on the same day. In the middle of a war, so not much traffic between Paris and Berlin, and no transatlantic air travel at all on the same day. And London, the large dots there, 1 week later. What is the explanation? Nobody knows. So was it subclinical in a population, and then a weather event or something else happened, and suddenly it took off? We just do not know. So to bear that in mind. Then when we look at other pandemics, so 1889, 1892 influenza, of the all-cause percentage of influenza as opposed to all mortalities, 10% first wave. And so March 1890, then we come to June 91, 45%, from 10% to 45% mortality. And up again, these are the numbers that actually came down. 1918-19, 5%, then we see it jumping up. 57-63, 43%, and similarly 1968, 1970, 15%, 85%. So we just be mindful, will that happen? Next steps. So it's a new pathogen. It highly, with that rho value, a lot higher than ordinary. Why is it linear? We don't know. Maybe it's because of the longer incubation time than seasonal influenza. And maybe it's travelling subclinically more. We just do not know. We can see the economic and social impacts it has already. Vast, vast, vast. It is not SARS and it's not influenza, as I've said. It's quite different to SARS. Everyone got major clinical symptoms with SARS. SARS had a 10% mortality. And we need to be slowing the transmission, if anything, so it's easier to manage, even if the same total number of people succumb to it. As with Norovirus, for instance, we don't want Norovirus to go through a facility in one day, because half the staff are off and the patients all need 3 times as much care. So even if the same number can come down with it, in a worst case scenario, the same number come down, spread over 4 or 6 weeks, then it's easier to manage. It's called flattening the curve, easier to manage. So as I've said, always clinically severe cases, and we can isolate all positives with SARS, 10% mortality with SARS. Influenza, the seasonal one, more like a 0.1% mortality, and children are significant vectors for the seasonal one. We need to assess local risks and trying to contain at the time, and there'll be a difference between no cases versus sporadic cases. We start upping the game in the sporadic versus clusters. So we got 5 in that area there somewhere. That's getting into cluster versus actually it's away in the community. And we change our responses with each of those. More social distancing, banning meetings, etc., etc. We need a sustainable approach while minimizing socio-economic impact will be the strategy. Community action. The majority of infected people recover. But isn't everybody petrified? And that creates its own troubles in itself. So frequent hand hygiene, always covering mouth and nose for any cough becomes critical. Continually update about it. WHO site, CDC, MOH, continually update, because we don't have much, we only had 3 months information so far, and it will evolve and change. Support additional responses as required and try and let people know these will be coming, so it suddenly doesn't come as a shock when it happens. They've pre-thought through it. If we've pre-thought through something, and that's why I mentioned those following waves, it's not to frighten people, just so we're aware it could happen. And we need to foster social cohesion, so get phone contact going for meetings and sport and faith, but just in communities overall. If people are ill, we need to keep up that phone contact as much as possible. Same if patients are isolated. We know any isolated patient has higher fall rates and worse medical outcomes as a result of being isolated. So think of the psychosocial issues around that. COVID, national epidemic curve. So in China, fantastic. So it will come down at some stage. And for the rest of us too. We don't know when, how high this will get, and when. But China have done, they may or may not have been a bit slow off the ground for a start, but they've certainly been staggeringly amazing what they've done since then, and there's a lot to learn from them. In China, patients with COVID-19 are not permitted visitors. We have to make up our own on that. Staff use all these things. I must say I'm against, well, I shouldn't say that. I have some doubts just how important gloves are, because if we're doing really good hand hygiene, we have no nicks, we're not going to come down with something if we do good hand hygiene. But that's typically, we do say, or WHO, CDC say you must wear gloves with droplet precautions too. Just if they ran out, it wouldn't worry me so much. Patients discharged in China after clinical recovery, which is afebrile for at least 3 days, resolution of symptoms, and radiologic improvement, and 2 negative PCR tests required in China, taken a day apart. But there are now starting to be a lot of relapses. Somebody's just asked, lady, husband and child travelling to Aussie in June, lower risk group for age, comorbidities, but child has mild asthma. On the whole, children have a really low chance at the moment. The asthma, there's no right answer of whether one should go based on evidence. I always would put it this way, if you went with your child with asthma and they happened to get it severely or in the worst case died, would you have regretted going? And of course you would, so you're damned for even thinking through it that way. I'd be reluctant knowing that it's increasing so fast in Australia now, really starting to take off. And we know, incidentally, those that don't know, the health minister in the United Kingdom has just got a positive COVID-19 result. So, COVID-19 detected in respiratory fecal blood sperm on preliminary data as of 20th February. Virus detected in upper respiratory samples 1 to 2 days prior to symptoms, as I said before, persists for 7 to 12 days in moderate cases, but up to 2 weeks in severe cases. And so we know it. It's coming. It's not going to go away in a week or two. It's likely to keep on going almost whatever we do. We're trying to flatten the curve as much as possible. And we know the basic steps we have to do. 1.5 meters, 6 feet, whatever, around, cover every cough. Wear a mask, try and not let the air get out, just push. We know surgical masks with SARS worked just as well as N95s when they were worn really properly. So we know N95s are higher level, but there were hospitals in Asia that could not afford N95s where no staff caught it. And there's hospitals in Canada that only had N95 where staff caught SARS. So even though N95 is definitely better technically than surgical masks, the way we wear them is probably equally to more important still. So new cough, always wear a mask no matter what. Lessons learnt from SARS, And are those relapsing in China sick or considered infectious? We don't know enough yet. That's a question that's just come in. They are sick. They come back in febrile. So they completely cleared it, but they've come back in febrile. And they tend to be those that have lower cellular immunity and are more older. So pretty scary to think that there are those coming back in again. They've been cleared, PCR, whoop-de-doo test, and negative. So one country's infectious disease goes to another, international air travel, and large negative economic impact. How's it ever? High-level commitment for containment, yes. WHO critical for cooperation support, spreading information, and we're sharing information like seldom before. In perspective, infectious diseases. So influenzas, pneumonias, way up here, AIDS, diarrheal diseases, TB, over 1.5 million deaths per year every year. And so we see malaria just short of 1.5 million every year. We factor those in. These things like car accidents, we factor. I'm not saying this is not really, really serious, because it is, but car accidents, we have 350 to 400 a year, twice as many suicides, and somehow we've factored that in. So the unknown, so the more we can know what we have to do the best we can to mitigate the risks, And antibiotic resistance, it's predicted maybe by 2050 there'll be 10 million deaths a year. Comparative fatality rates, seasonal influenza 0.1% or less, so that's 1 in 1,000 or less. COVID perhaps 3.4%, but we just do not know what the denominator is. It may be quite a lot lower than that, maybe a lot lower. But these SARS H7N9, which didn't take off, was 30%. Middle East respiratory syndrome, 34%. If the bird flu have got going, just staggering. We know what the sort of 1, 2, 3% will do compared to the bird flu if it got going. And Ebola's 90%, but we have to have blood or body fluid going through. Questions come in with no hand sanitizer available to buy. What can public do to protect themselves when flying, etc.? It's a good question. Do nappy wipes provide any protection? If you couldn't get any alcohol wipes, I would use a nappy wipe, actually, because the detergent on them would even help disrupt. I'm not saying it would completely do it, but it would go a long way to disrupting COVID virus. So detergents will disrupt it significantly, so a nappy wipe would be worth considering. Remembering what I said about the trays, those security trays, anything you touch. I'm right-handed, so I try and use my left hand where I can, and pin numbers and lifts and such like, I use the knuckle of my left hand where I can to help mitigate the risk. Just little tips to use along the line. And if I'm coming out of a public loo and there's no paper there, I use my shirt with my hand behind it to unlock the door, just to mitigate the risk. Why did 2 doctors in China die as they looked young? Underlying medical conditions. I think it's a good point that we don't know enough about yet, but the more exposure, say over a morning you see 10 patients that have got COVID in a hospital, you're going to be taking in more virus, bigger numbers. I think, but the data's to come out yet, it's likely to be that higher dose, which was their downfall. I'm not aware of them having underlying conditions, but they may have. So thank you for that question as well.
We've also got one on the chat as well from Paul. He says, if no fever at admission for large proportion of patients, what are the presenting symptoms of severe critical cases?
So difficulty breathing seems to be major. Difficulty breathing with severe cases. That's really major. So somewhat like influenza, but that difficulty breathing seems to be noted by most of them in severe cases. Really, really difficulty breathing. It's a pneumonia, and fully fledged pneumonia, and that would show up, if we're able to, that would show up on CT scan as well. But I think the difficulty breathing is a major one.
Yes.
We've got they're coming now. The questions have started. So we've got another couple here. We've got it says, "Hi Ben, why is COVID so serious? Is it because it attacks the respiratory system?
Why is it so serious? Any virus or bacteria, it has to mutate to, as I said, most of these bugs stay in one species only. But when they're as unstable as RNA viruses, and there's hundreds of millions of the virus ongoing, so whether it's in waterfowl for influenza and such like, when one has got to go through a number of mutations before it can get into another species. It's got to mutate to, in this case, COVID may have gone from bats, and it may or may not have gone into the pangolin anteaters, but it doesn't matter, but it's mutated to get there. Somewhere along the line it's either gone through an intermediate animal or from bats straight off, or another intermediate animal. It's got into humans, and that's right. If it just got into a human and stopped there, then we'd have a small number of cases where it's happened. But somewhere along the line it's mutated enough to get into a human, and the human's got ill, and then it's mutated enough to be able to transmit from human to human. It's a different mutation again, and to cause infection enough that that person coughs and spreads it. And because humans have never had any contact with that COVID virus, we have no residual immunity at all to it. And so that makes us very, very vulnerable. I think that's probably the nearest I can say to it. When something has mutated enough to be able to effectively go from human to human, and we have no residual immunity. So if this comes and, say, like swine flu was a little bit different, because that was in a pig, and a bird flu virus, new bird flu virus got into the pig at the same time as the pig caught the seasonal influenza, and the two mixed up and then came back to humans. So we'd partially seen it, we'd half seen it, we had some residual immunity. But when a whole new strain comes like SARS or MERS or COVID, we have no residual immunity. If it keeps going, then after a year or two we will have all had contact with it. And then it'll either become one of the seasonal influenzas that don't affect us nearly so much because we've now got a residual immunity, or it will die out, one or the other. And it may come back as a second wave and be worse if it's mutated that way.
And then we've got a few more questions. So
That's
we've got,
yeah, no trouble.
So this one here says, this disease looks like it might be more dangerous than Ebola. Is it a bit more dangerous as flu, as this disease looks like the same?
If I understand that, Ebola mortality rate was 10%. This is more likely, we don't know yet what the mortality is. It may be 1%, it may be 2%. So SARS will be at least 10 times worse, but everybody with SARS had very serious infection and 10% died. This, probably the majority of people will have so mild they don't know they've had it. So this is nowhere near as bad as SARS, nowhere near as bad as SARS. But SARS was containable because of those specific clinical features, and we didn't start showing them. So this will kill far more people. Only 800 out of 8,000 died with SARS. This has already killed far more people. So more serious from a worldwide perspective, but a lower mortality rate.
Okay, Ben, I think we'll let you finish your slides and then we'll go back to the questions.
I'll just jump through. No, that's. I'm going to jump through. I'll just do these ones briefly. Our actions are our future. I just put this up. There is some practical advice. This is the Canterbury Primary Health Response group, and that has there's a largely put together by Dr. Alex Shaw. There's a practical PDF online. You get onto this site, Primary Health Response, and then it's not nearly as bold as this. I've made it bold down the bottom. You click on that and you get to a PDF of a number of practical issues for general practice. So I've just put that on. And remembering, keep learning. Some people can't see what's in front of them. Key message, you don't know where anyone's hands have been. Once you touch something that somebody else has touched, There's plenty to be pessimistic about, but the more we know, we can manage risks and mitigate them. And we've got to do it with a vengeance. Those rest homes are really, really vulnerable. We need to be absolutely on the game. The happy anniversary to the glummest people you've seen on the world. They are vulnerable. These no more. There's nothing they can touch that other hands have touched. And maybe ignorance is bliss. But on the whole, these young ones, they don't seem to be getting it at all at the moment. Yes, so more questions, please.
Okay then, so we'll go back over to the chat one here. So we've got, if one person family has been infected, does the whole family need to be quarantined? Can our pets get infected from humans, and how can we know that? Can we get infected from our pets?
At the moment, from the pets, I'd have to say no, as much as you can ever say no. There's no known instances of it. If you've got a pangolin anteater at home, you may be a bit more concerned. But in practice, it is rare. This is a rare occurrence for a new species to go from an animal into humans. That's the first thing. For those in isolation, if there's a case at home, at the moment, while it's still in cluster or individual control, I think everybody would probably have to, because they would have had contact beforehand, everybody would have to self-isolate. And that'd be best to be isolated, sorry to interrupt, that'd be best to isolate from that person as well, because they may not have caught it, and to reduce their risk as well, their individual risk. Yes, next.
Have a room each in the house, eh?
That's right. Yeah. Shut the door and slide the pancakes under the door.
How to differentiate between the flu and COVID-19?
That is the trouble for most. You cannot. That's what I'm saying. And one of the risks, and this is going to be unpopular to say, but one of the risks by holding it back, we may be tilting it in to the same time as the influenza comes, its annual influenza, and then we have a trouble because if it came at the same time, there's not going to be enough testing capacity, and we just will not know. Effectively, the treatment is the same though. So the treatment for COVID-19 and influenza is the same. Isolate, isolate, isolate. And essentially the treatment, and you may never know, did this person die? If it really comes large, the testing will nowhere near be able to do the test required. And there may be a patient in a rest home that dies. Was it influenza? Was it COVID? We may not know. In the early stages we would. There'll be enough testing capacity, but if it comes on, there won't. So we have to assume that anyone with influenza-like symptoms, remembering that can be just a cough, could be COVID, and it cannot be differentiated. More serious, we get into the serious breathing difficulties. Yes, next.
Right, so the next one is we've got how long does hand sanitizer last for? Some people are digging out old ones that they had forgotten about. Will they still be protected?
I have a favourite expression with this. If you had a bottle of gin or whiskey that was 10 years old, would you throw it out? Do you think the alcohol would have lost? What I'm saying is, if it's really old and it's still up to the same level, then the alcohol will work 100 years later, no trouble at all. If the bottle's been somehow opened and it's a brand new but it's evaporated down to half, then it may not. So effectively it'll keep working ongoing. Mm-hmm.
And then we've got is it correct that soap and water is more effective in breaking up the COVID virus than alcohol-based sanitizer?
It may be. I think the alcohol, on what we know, works just as well, but liquid soap and water really disrupts the COVID. Theoretically, I'd say yes, soap and water is just as good. Where that changes the balance is compliance goes up a whole lot more with alcohol. So if it happened to be, and it may not be 10% better, but compliance is 30% better with the alcohol hand rubs, which is better. And so in practice, it's quite a fragile virus. Liquid soap and water will kill it well, and I think alcohol will kill it. Alcohol hand rubs will kill it well too. Just make sure you do it.
And then there was news that China had confirmed they have an H5N1 at the moment, apart from the COVID. Is there a possibility that since COVID is an RNA virus, and as you said, it is unstable, it will possibly combine or mutate with H5N1?
No, it won't. As much as you can never say no, it won't. Because we don't get a coronavirus intermixing with an influenza virus. So the coronavirus could mutate, the H5N1 could mutate with another influenza, but it will be like a 1 in a million year type event to go with another species as such. So I think we can reasonably say no.
And say, are antivirals of any help?
We are too early to know yet. There's a whole, remember, only three months it's been going. There are a number of potential possibilities that may help, but I just put it to you, if they did help, there won't be enough. So if there's, say it was an HIV drug, for instance, that retroviral was working, there's only enough for the known and a little bit more for the known HIV cases, and suddenly you've got thousands more required. So I think it's too early. There's some hopes from a number of different drug types, but they haven't been convincingly published yet.
Is there any evidence that second exposure to the virus can cause more serious illness, as in dengue?
Second exposure, hopefully, is unlikely to happen because you have immunity from the first exposure. Having said that, I said there's relapses. Within a family, some of these viruses, though, we know within a blood-related family, so genetically related, so one parent and the children, or the other parent and the children, as the virus goes through, it can get worse. It can get worse within a family. So it already starting to know how to overcome that first genetic type, the second one, yep, I know a bit more, third one. So it can get worse within a family. So isolate well if one member is ill of a family. Isolate yourself, but isolate them as well. Yes, good question.
And then we've got vaccine development of COVID. What is the best advice regarding the 2020 flu vaccine for patients, particularly over 65 in New Zealand?
The best is to, on the current one, is to vaccinate as many people as possible for influenza. If anything, the under 65-year-olds, we need the workforce. We need the workforce, and we don't want them to be admitted to hospital and crowd out the hospital. So if we can reduce that influenza rate by half, and it'll stop people being petrified if the two are together at the same time. That's the first thing. As an aside, and it's probably not the right place to mention it, but I would like all under 16-year-olds to be vaccinated for influenza, and that has a 65% or thereabouts efficacy for the over 65s, even if they're not vaccinated. But that's another topic. But it works remarkably well by vaccinating the children. So for influenza, they're significant vectors of spreading horizontally, the children are, and then upwards. So we need to really, it would be ideal to vaccinate the children too, under 16-year-olds.
Right, and then we've got coming into an influenza season and working in the ambulance setting. Based on your evidence, are you suggesting that all patients with a new cough need to go to hospital after hours? We do not have after-hours GP in our area. Rural hospital is where we take our patients. The staff and facilities will not cope with that demand. Most of our patients are elderly.
Okay, I think that's a good question. I'm certainly not suggesting at all that anybody with a new cough should go to hospital. What I'm saying is anybody with a new cough, it could be influenza or it could be COVID virus. At the moment, COVID's less likely, but as it becomes likely to be more community-borne, we just do not know, and we don't want to spread it. So the first thing is to wear a mask, good hand hygiene, isolate yourself. That's key number one. So whether it was not influenza or not COVID, it doesn't matter. We don't want to spread it. If it happened to be influenza or COVID, we do not want to spread it. And the only way we know is by wearing a mask, hand hygiene, and isolating if the cough's getting worse. There's going to be judgment calls on how ill are you before you present to a centre, but even then, there's not much can be done. It can be paracetamol and fluids, whether it's COVID or whether it's influenza. But starting to get seriously ill, then we have to phone ahead and think of hospitalisation or a medical consult somewhere.
Okay, so the next one we've got, is there already a possible reason why the virus seems to evade the younger population, or that there was minimal confirmed cases to the younger population? Now that also follows to the next question that says, despite children not showing signs of COVID, are they still carriers or able to pass it on to others? So I guess just around that sort of younger population.
Sure. They're both good questions. I don't know if anybody does why children do not seem to get it clinically so much. Perhaps their cellular immunity, the macrophages, work better. That seem to be a significant part of the COVID virus. And maybe that's why the elderly, the macrophage is starting not to work so well. They don't have a memory macrophages, unlike lymphocytes. Maybe that is why. As far as carriage, the seroprevalence studies, to the best of my mind, have not been done, so we do not know if children are carriers. But if they are carriers, same as influenza, it's believed to be rare, like really quite rare, that you pass it on when we're asymptomatic, either with COVID or with influenza. There's very little evidence of influenza being passed on, in spite of what the WHO said a while ago. Published papers, there's very little evidence of somebody without symptoms passing it on, other than direct respiratory secretions, kissing, etc.
And then we've got, how are the nurses and doctors protected when they treat patients in hospitals?
By the same way. Because they're seeing more patients, they may take even more care on eye splashing. We don't know yet, only 3 months, we don't know yet how much the eyes are a risk. I suspect not nearly as much as the respiratory, so the mask, the level will be upped more and more and more to try and protect them until we know more. Maybe the eyes are a risk, maybe they're not, but they will be wearing N95 masks in a hospital, and their habits will be better and better, hopefully. Yes.
And then we've got, do we know the percentage of representing cases?
The percentage of relapsing cases?
Representing
cases. No, but they've been, the wonders of Google, I've got translated a Chinese paper just came out, and there are quite a number of them. Not out of their 80,000, but a number of cases have got really solid. So it's going to be small as a percentage, but we've still more to learn on that. So after they've been discharged, because they've had 3 negative PCRs, if we've got enough capacity to do the PCR, whether it's a rest home or a hospital, and they've clinically recovered, and their chest x-rays got better, still monitor them closely for 2 weeks would be the best advice to try and pick up relapsing.
And then we've got, in your honest opinion, do you think this virus will last until the end of the year or early into next year? Ooh. Do you know the lottery numbers as well?
My honest opinion is yes, it will. And maybe it's harder because if it keeps sputtering on, and because of this very low, most cases are mild to moderate symptoms, I can't see how it would not keep on spreading and maybe keep popping up in hotspots ongoing. Now, whether that's New Zealand, whether it goes through and then the fear factor drives everyone to stay at home, and so it doesn't spread anymore, then they come out, start working again, so it starts spreading again. We've yet to learn that. But I cannot see really why it couldn't keep going. But we don't know, why has it taken off so much in Italy and not other countries so far? Why did it suddenly balloon in Italy? And we tend to think these things often get worse in the winter time, but Singapore's had its cases too. And now it's starting to take off somewhat in Australia, I think, and England. And they've got 1,000 cases in the States now. So I think that it suddenly comes to an end. Always unpredictable, it could do. I personally think it's very unlikely at the moment.
Okay, and then we've got, this an interesting one too. We've got, will the cough medicines available over the counter work for COVID cough. What type of cough do we get with COVID, dry or wet?
I am pretty sure it's a dry cough, and so cough medicine, I'm not sure. I don't know. I haven't seen anything published on it, but it may or may not. Most of them don't work that well.
And then we've got, someone says, the Dudes concert Auckland Town Hall in April, or any enclosed gatherings. Crystal ball predictions.
Your guess is as good as mine. It depends how fast, assuming it does start spreading in the community and we're flattening the curve. Clearly, the more people that are together increases the risk. Now, what level society wishes to change its habits to try and mitigate that risk is basically a question for attendees to decide. if it's not imposed on high.
And then we've got, someone says here, they said, Ben, actually we're using surgical, not N95 masks in hospital as it is droplet spread, unless they're doing an aerosoling procedure. Could you please clarify this?
That's right. Aerosol procedure will be a lot worse. So we've got droplets coming out, say, from a lung, and so that's going to have a lot more virus, so it raises the risk, any aerosolized procedure. I think it will be premature to use N95 masks all the time now and use them all up, and in 4 months' time, if a whole lot of COVID starts becoming more and more common, we start having a peak then and think, oopsie daisy, we've used up all the N95s. I think that would be premature to do it that way. So it makes sense to me to hold those until such time as we may get a bigger percentage of them. Bearing in mind what I said, the way we wear them seems to out-trump the technical specifications themselves, on some evidence from SARS.
Okay, and then we've got, what advice should we be giving people about unnecessary overseas travel with no risk factors?
I get asked all the time. I think the risk at the moment is basically there's no insurance. So you go to any of these countries and you get ill and you get hospitalized with COVID. There's no insurance for epidemics, pandemics written into all the policies now. You lose your return flight, you pay for the hospitalizations. Somewhere in there, you have to work out what you're prepared to pay in the worst case scenario. Sorry to interrupt, or if the country you are in, say you'd gone to Italy, somebody asked me before they closed down Italy, would you go to Italy? And they're in healthcare, and I said, actually, I would not, because you like your job, you have a fantastic holiday, and you'll be isolated for a month when you get back. And they said, I didn't think of that.
Yeah, it's the add-on that you've got to put back, sort of adding on that possible 14 days at least isolation, isn't it, as well, even if you do get home okay. Yeah. Look, the questions just keep rolling. Are you still okay to answer?
I'm fine, yes. Absolutely, yeah. Thank you.
And so we've got here, what are... all right, so let's go to this one. Is there any active research being done or immunizations for COVID-19? If so, how long would it take to get one?
Stacks of work. There's a dollar to be made and hundreds of millions of dollars to be made. Some of the challenges include having to take a part of the COVID virus, which is going to be stable, so if it mutates, it's still there, and we know how much trouble that is for the seasonal influenza. So take a stable part of that virus, try taking that part and putting it into animals to see, does it give a reasonable response, not too much of a response, because we don't want somebody to get a severe infection from a COVID, a severe response, not an infection, a severe response from a COVID vaccine. We just want to like with influenza, you may get a mild response, so we've got to get the right sequences to give a light to moderate response. And so it's tried on animals for a start, and does it produce that immune response? Then it's tried on a small number of people, and to make sure there's something not obviously different to animals. That's phase 2. So phase 1 animal, phase 2, small number of people, then phase 3 trial, for a large number of people, maybe 1,000 or 2,000, phase 3 trial, were there toxicities or unintended consequences that weren't realised in the smaller ones, then yep, ready to go. How do you suddenly make 4 billion doses of this? And then there's the distribution networks, etc. It's not going to be quick unless there's a whole new technology suddenly became available. So year, 18 months, we would have most likely been exposed. Year to 18 months minimum, I would have thought, we'd most likely be exposed. And then we don't know how effective that vaccine is. Is it like influenza, not too good for the over 65-year-olds at all? That's only around 25% or so for the over 65-year-olds. We just don't know.
And then we've got, do you think weather changes will have any influence on COVID-19?
It's interesting. Once again, we don't know. The 1918-19 influenza that came back for a start. The first wave was in the summer, but just a bit of a blip in the Northern Hemisphere. Then it came back the first wave was in the summer, 1918-19 in the Northern Hemisphere. Second wave came back in the winter. Second wave came back in the winter, November, December. So when we're closer together in the winter, because it's colder, we spread droplets more readily. And so, but trying to explain that 1918-19, why did it suddenly take off and across the Atlantic? Nobody knows. Always unpredictable, never forget that. But we know what we have to do to mitigate risks.
I know what you're doing when you can't sleep at night, Ben.
I sleep very well, believe it or not.
And so we've got, and someone's saying, is any idea how long to isolate for? Is it similar to flu?
Well, the current recommendation is that 2 weeks, I think. And so that's got a little bit of safety backward in there too. Just somewhere in there, I know we're unlikely to be spreading it if we're not coughing. So if it got worse and say you're in a rest home, what do we do? We've got no staff because a number of them are off, we're really desperate. At some stage we will need to make these judgment calls. The person feels well, they're not coughing. So imagine they may have the virus in their secretions, but if they wash their hands, wear a mask, the risk should actually be very, very low for those people. But we can't use that for the public in general because they're not as tight on their knowledge as healthcare workers.
And then we've got, what is the advice regarding nebulized therapy in primary care for a patient with symptoms which might not be COVID, when not practical to transfer all to hospital?
So I think at the moment, it's always going to be a judgment call. We know if there is this continuum of changes, if we believe there's very little transmission in the community at the moment in New Zealand, so the nebulizer, that risk is going to be really low. As the clusters get more and more common, then we know nebulizers are a risk. We normally will not know if that person has influenza, COVID, or another respiratory virus, but we have to assume they may do. And so there's going to be risk based on that. Incidentally, just slipping in there, talking about sleeping at night, we know our immunity is better if we have a good night's sleep and we keep fit and healthy and we eat well. Do not underestimate these other soft measures of helping our immunity. They definitely work. Sorry, next question.
Right, we've got any recommendations for community-based private allied health clinic to prevent the spread of COVID-19? Standard screening questions, etc.
Cleaning will be that diluted bleach that I talked about. 0.1% bleach is the main one, although alcohol wipes on bench tops, etc., and stethoscopes should work well. As far as, and that will be, we have to remember that the so-called red streams and green streams, will not know if someone's got COVID. We'll know if someone's got serious infection, but we will not know if they've got COVID or influenza. And we must protect as though they do all have COVID and do our infection control with that in mind.
We've got some of these are maybe getting a little bit clinical, but I saw a child with croup more than a week ago, seen again today, and still bad cough. Should I be testing for COVID?
Based on the overseas evidence, I think not. As it happens, it's just, unless it changes, and this data, mate, we've only got 3 months, it's just so unlikely at the moment, I think. And you can see the trouble with testing as it goes on. There'll be thousands of tests we'd like to do, and there won't be the capacity. But we have to do a risk base. It's unlikely for children to succumb to it.
This is probably more a comment than anything. So just someone says, we've been told that we're not to nebulise patients in our primary care practice, as in many cases, an inhaler with a spacer is just as good as a nebuliser. I think that's sort of a little bit...
That's right. The recommendation is not to nebulise, but if someone was getting reasonably critical, you're going to have to make some decisions there on what am I prepared to risk, and or how likely do I think it is based on the current known community transmission in your particular area or their travel.
And then we've got someone's just saying, so you have said this, but just to confirm for them, they're saying, just to confirm, in primary care, no proof of aerolization, even with nasopharyngeal swabbing. So not necessary yet for a blanket N95 mask recommendation.
I'm not sure if I understood that question.
Yeah, it's on the chat. So personally, I would be thinking it's more if you're doing the nasal or oropharyngeal swabbing, you're up very close to the person. Under those circumstances, you'd possibly be more inclined to go N95 with your full protection if you're not just in the room with the person, but actually very close in there.
Yep. So now I understand what you're asking. And what you said makes sense. Bear in mind with nasal swabs that, including in New Zealand, one of those cases, I think the first 2 days symptomatic, took the per-nasal swab and it was negative. Third day it was positive. So that may be because it's generally believed, and we'll know more in time, that the virus would have been there. And bear in mind with a per-nasal swab, we're aiming for a spot a long way away from the entry point, around some blockages. We don't know if we've hit it or not. And so many people have not collected many per-nasal swabs. Personally, incidentally, I like, with got gloved hands on, just bend the end bit about 10 or 15 degrees. It goes around the corner better.
So one here is asking, of the people who are representing with symptoms post being cleared, what are they representing with? What is their symptoms?
Febrile, ill. Yep. They come back with a full, they're ill. Yep. They become febrile. It's tended to be within 2 weeks of all those clearances. 3 days, PCR negative, chest x-rays got better, no symptoms, two PCR negatives on different days, and then they're fine, and then it seems to come back again. Small number, but be aware of it. Sorry. Yep.
I was going to say, apart from frequent hand washing, what other advice would you give to people working with clients in the community, such as community support workers, social workers, etc.?
As leaders, show confidence in covering all coughs, not just those that seem as though they'll be bad, all coughs, and hand hygiene. Once you've touched something that somebody else has touched, it may be contaminated. Stopping the habit of touching your face, which includes the eyes, nose, mouth, and equally importantly, being aware of things like finger food. Be aware when you go to supermarket to get fruit. I've seen many people in supermarkets cough over the fruit and or cough into their hand, pick up an apple, decide, no, they won't get that one. They'll get. So just be aware of that. That supermarkets, etc., once people realise things like that, we don't need to be paranoid, we just need to know it, implement it, and have sufficient social cohesion that we don't feel embarrassed to point it out. Listen, would you mind, or did you realise you're coughing into your hand? We need to up our game.
We've just got someone who's commented that they saw recently when they were in an ED department that the doctor, when they were doing the swab, stood behind the person, so as if they coughed, that they weren't in direct line for it.
It's a good idea. And something else with that, I mean, that's an excellent idea. And just need to practice that a little bit to do it, because it's quite nice also that they can't tip their head back more if it's pushing into you. Otherwise, I tend to sit the chair so the wall's behind, and they can't move away from it, because everyone moves away and everyone coughs after it. So it's a good idea coming in from behind. Thank you.
Okay, and here's your last one. This is it, then we're wrapping up. There's lots of people saying thank you. They've loved your conversation and found it very informative, but we've got one question here. It says, due to COVID-19, there is a shortage at the moment of N95 masks or even surgical masks. What are the alternatives? Also, are aerosol disinfectants safe to use?
There's a number of things in there. So if we were to go in a worst case scenario, and you'll never see this published, if I had a couple of surgical masks and I could see they're going to be running out coming up over the next week or two, I would write my name on it and keep my surgical mask, and I would look up the temperature, which I meant to do before coming down, that's likely to be inactivated by, and I'd put it in something heating that might be 70 degrees or something that killed the virus, and I'd reuse it again rather than use nothing. Actually, that's what I would do. Or maybe give it a wee squirt with if I had alcohol, 70% alcohol without the gel on it. So the meth, I'd give it a wee squirt. Pure alcohol does not work as well as diluted. And so in a worst case situation, I'd squirt that on, 70% alcohol, and just take a couple of squirts, and then reuse that mask again. And rather than use nothing, that's what I would do. It's good questions. Whereas if I'd run out of gloves, actually that wouldn't worry me at all. I think,
no, it's
I don't see the need for gloves in this situation as it happens, but so long as you don't have nicks or cuts on your hand.
Someone's given a wonderful suggestion that you could soak it in some Jack Daniels.
Good idea. And the thought at the end of the day, going back to the source of what that fragrance was in the mask, might keep you going.
I was just thinking you might stockpile it like your toilet rolls, Ben.
That's right.
Much cleaner option, but no, that's wonderful. Thank you very much for all your information and your time this evening. I'm sure it's been well appreciated across New Zealand. You had over 200 people log in and listen to your conversation, so hopefully that will alleviate a lot of questions and queries that people have, and will help them in their clinical practice going forward after today. So thank you very much for your time this evening.
You're very welcome. Thank you for all the attendees. I'm sorry I can't see you. You can see me maybe, but thank you for your attendance. Any feedback on how I can do it better next time, please let me know. But thank you for all your comments.